To manufacture a single batch of intravenous immunoglobulin, or IVIG, pharmaceutical labs must pool the blood plasma of up to 15,000 human donors. Managing a donor pool of this size introduces severe logistical constraints. Every batch requires rigorous screening for HIV and hepatitis, followed by advanced viral inactivation and purification steps to prevent the transmission of bloodborne pathogens. The result is a highly scarce biologic resource. A standard 2 gram per kilogram dose of IVIG costs a hospital approximately £10,000. Despite this cost, intensivists prescribe this exact same pooled infusion for drastically different clinical emergencies. It is used to treat systemic infections driven by bacterial superantigens and progressive paralysis caused by autoimmune nerve demyelination. IVIG operates through highly complex multi-pathway immunomodulation. It actively interferes with the patient's cellular machinery across several distinct systems. Because it exerts these pleiotropic effects simultaneously, deploying IVIG safely in the intensive care unit requires physicians to decouple its distinct molecular mechanisms. This schematic illustrates the basic structural anatomy of the immunoglobulin G, or IgG, molecule. It is a Y-shaped protein divided into two primary functional zones, the variable, or Fab region at the top, and the constant, or FC region at the stem. The Fab regions are responsible for antigen recognition. By pooling plasma from 15,000 individuals, a single batch contains a massive diversity of these variable arms. This equips the infusion to latch onto and neutralize nearly any exogenous antigen or bacterial superantigen it encounters in the bloodstream. The FC region serves a different purpose. The stem of the Y-shape physically binds to and saturates Fc gamma receptors on the patient's own effector cells, like macrophages and natural killer cells. Once these receptors are plugged by the infused IVIG, they are blocked from functioning. This prevents the patient's endogenous autoantibodies from binding to those cells and triggering antibody-dependent cellular cytotoxicity. IVIG also directly inhibits the dysregulated activation of the complement cascade. It physically interrupts the chain reaction of complement proteins, providing anti-inflammatory protection that lasts for 2 to 4 weeks. Furthermore, IVIG modulates B-cell function. It downregulates the expression of CD21 on B cells, which actively induces apoptosis and resets B-cell homeostasis. When we map these specific physical interactions, FAB neutralization, FC saturation, and complement inhibition, the diverse list of intensive care indications resolves into a precise set of targeted biochemical interventions. We observe these mechanisms directly in patients presenting to the ICU with acute neuromuscular respiratory failure. In Guillain-Barré syndrome, autoantibodies attack the myelin sheaths of the peripheral nervous system. Flooding the patient with IVIG provides a massive dose of constant regions that outcompete the autoantibodies for Fc receptors, halting the autoimmune damage. The same principle applies to severe exacerbations of myasthenia gravis. IVIG receptor blockade protects postsynaptic nicotinic acetylcholine receptors from being destroyed by the patient's own immune system. For Guillain-Barré, intensive care physicians often choose between IVIG and plasma exchange, or PLEX. High-quality Cochrane reviews show both therapies are equally efficacious at reducing disability scores and the time it takes for a patient to walk unaided. Clinical data indicates there is no benefit to combining the two treatments or crossing over between IVIG and plasmapheresis if the first option fails. IVIG holds a distinct logistical advantage. It can be administered rapidly through a standard intravenous line, eliminating the reliance on specialized apheresis machines and the highly trained technicians required for PLEX. The therapeutic window, however, is strict. An initial course of IVIG must be started as early into the disease course as possible. If more than 4 weeks have elapsed since the time of diagnosis, the infusion is contraindicated due to a complete lack of suggested benefit. For neurological crises, IVIG-IG effectively replaces the slow, physical extraction of pathogenic antibodies with rapid, equipment-free cellular blockade. Moving away from the peripheral nervous system, these biophysical mechanisms are equally critical for hematologic and infectious disasters originating in the bloodstream. In streptococcal toxic shock syndrome, bacterial exotoxins act as superantigens. They trigger T lymphocytes to initiate a massive inflammatory cascade. Here, the Fab regions of the IgG molecule perform the necessary work. IVIG passively transfers neutralizing antibodies that bind directly to the superantigens, inhibiting toxin production and halting the release of interleukins 1 and 6, as well as tumor necrosis factor. The Fab mechanism is also deployed for extremely rare presentations, such as vaccine-induced immune thrombocytopenia and thrombosis, or VITT. VITT is specifically linked to the 4 to 42-day window following vaccination with either the AstraZeneca or Johnson & Johnson COVID-19 vaccines. In this condition, patients develop endogenous antibodies against platelet factor 4, leading to severe arterial and venous thrombosis, often in cerebral and splanchnic circulation. Administering IVIG reduces these anti-PF4 antibodies and directly prevents further systemic platelet activation. A similar logic drives its use in post-transfusion purpura, a rare complication where the rapid destruction of platelets is halted by neutralizing anti-HPA-1A antibodies. Whether intercepting a bacterial exotoxin or blocking a severe endogenous immune response, the sheer scale of the 15,000 donor pool statistically ensures the presence of a matching neutralizing Fab antibody. Because IVIG acts on multiple immune pathways, there is a persistent clinical misconception that it can be administered as an empirical rescue therapy for undifferentiated critical illness. This flowchart displays current clinical pathways which explicitly reject this practice. For conditions like necrotizing fasciitis, a lack of high-quality evidence has led to IVIG being removed entirely from modern commissioning guidelines. Similarly, there is conflicting evidence regarding immunosuppression for life-threatening mucocutaneous conditions like Stevens-Johnson syndrome and toxic epidermal necrosis. Furthermore, the Infectious Disease Society of America recommends against its use in undifferentiated septic shock, where the causative organism is completely unknown. Due to extreme scarcity and high cost, prescribing IVIG requires strict adherence to pre-approved criteria set by national blood authorities or sub-regional immunoglobulin assessment panels. Administering a 10,000-pound biologic without a defined molecular target drains blood bank resources and actively exposes the patient to severe biophysical harm. Administering IVIG carries inherent dangers. Protocols mandate aggressively titrating the infusion rate up to 4.8. High doses physically alter the patient's serum, significantly increasing blood viscosity, driving up procoagulant factors, and causing widespread platelet activation. This hyperviscosity translates directly into severe clinical risk. Patients face elevated rates of deep vein thrombosis, pulmonary embolism, myocardial infarction, and sudden stroke. The biophysical toll extends into the renal system. Acute kidney injury is a known delayed complication, typically presenting between days 5 and 10 post-infusion. The mechanism behind this acute kidney injury involves osmotic tubular cell damage, combined with the physical deposition of heavy immune complexes directly into the glomeruli. In rare cases, the infusion triggers neurological toxicity, causing aseptic meningitis or posterior reversible encephalopathy syndrome, characterized by hypertension, visual disturbance, and seizures. These biophysical risks compound rapidly in patients with advanced age, hypovolemia, or pre-existing kidney disease. IVIG is a highly potent precision biologic capable of rescuing patients from refractory immune crises. However, its capacity to stabilize cellular machinery is permanently paired with its potential to physically obstruct the vascular and renal systems.